Greetings. I'm Bruce Ovbiagele, Editor-in-Chief of the Journal of the American Heart Association, and also a past chair of the ISC Program Committee. We're here today to talk about the TRANSPORT2 trial, which was presented earlier here at the International Stroke Conference. I have the tremendous pleasure of interviewing Dr. Wayne Feng and Dr. Gottfried Schlaug, who are the PIs of the TRANSPORT2 trial. Welcome. First, congratulations on the completion of a trial, which in itself is a landmark. And then number two, congratulations on the completion of the first stroke recovery trial in StrokeNet. So if I may start, give us a little background to why you did this important trial.
Sure, thanks, Bruce. My name is Wayne. I'm at the Duke University School of Medicine. I'm the contact PI for the TRANSPORT2 study. This really all come back 10 years ago when Gottfried and myself started, work on, non-invasive brain stimulation for stroke recovery. And I was doing fellowship with him, and we really liked this device, which I gave a little kind of demonstration. It's very easy, powered by 9 volts battery. So 2 electrodes put on my motor cortex. It's portable. I can stand up. I can do the therapy at the same time. We saw that would be really great tool for many of those stroke patients who actually are resource limited. And then we, over the time, work together, have several papers being published, and then we've have a meta-analysis shows really nice, dose response relationship between the current density, which is the current divided by petacytes, and the motor reduction. And then we did a phase 1 study, and really showing, can do high dose at a 4 milliamp, which is safe and tolerable. And then before this, everybody just kept at a 2 milliamp. So that's really kind of background. Maybe, Gottfried, do you have anything to add?
Yeah, so before our trial, which is the first multi-center trial really done with that device, as well as a standardized efficacy-proven peripheral therapy, before our trial, there were mostly single-center proof-of-concept trials that had revealed that there was an effect, although the amount of effect that would be seen was questionable, and not all studies actually showed this. But most importantly for us, the outcome assessment wasn't always done in a blinded manner, where the evaluator for the outcome was blinded to everything, as well as the patients blinded to everything. So we improved upon these proof of concept trials that were done, not only by testing the highest possible dose at that time, but also being very rigorous about the trial design and having basically a triple blind approach where neither the operator of the device nor the therapist nor the patient knew what kind of dosing of brain stimulation they actually got. And then on top of this, we had the evaluator for the outcome measure also blinded with regard to the dosing, as well as blinded with regard to when in the course of the patient's assessment, that assessment was actually done, either before or after the trial.
So no, I love the show and tell. Dr. Feng, really appreciate it, and clearly a promising device. And thank you, Dr. Schlaug, for talking about the limitations of previous studies. And this is, of course, why your studies are extremely important. Can you speak to what the clinical problem is before we go into the trial and what you did? What is the clinical problem that this device and your particular trial was trying to improve upon?
I would say the predominant issue is, stroke is the leading cause of disability. And motor impairment, either the arm and or leg weakness, is actually the most common and the complications. It really affected, 7 million of and a stroke survivors just in the United States. But we don't really have a many, evidence-based approach. The only evidence-based approach we have is really intensive and task-based therapy, such as constraint-induced movement therapy, and which is only proved to be effective. But the traditional format of CIMT takes 6 hours. It's very hard to implement and in a clinical setting. And then even the modified fashion, it takes 2 hours. And then come with brain stimulation. Really, the idea is, can we amplify some of the existing rehabilitation therapy so we can boost the functional level and at least one step for the stroke survivors? So that's kind of overall the idea.
And I think in addition to what Wayne said, we have to rely that there is still some structural or functional intactness to the motor system or the corticospinal tract. So we measured that actually in our trial. And in general, I think across all single center as well as multi-center trials that have been done industry sponsored, usually those ones who still have an intact, even though it may be impaired, corticospinal tract or output system seem to be doing better. So we assessed that as well. And brain stimulation together with the peripheral rehabilitation therapy may enhance plasticity in the motor system or in the motor region or motor cortex that then leads to more reliable and probably stronger motor output, which in normal control subjects is usually measured as a surrogate marker of the amplitude of the motor evoked potentials.
I see. So a debilitating problem, highly prevalent, motor recovery, just one evidence-based treatment, CIMT, but which is very burdensome for patients. And so the whole goal was to try and enhance this evidence-based therapy by using this particular device. So so what was the design and the methodology for Transport 2?
So the design of the methodologies at that time was really, we actually, just as I said, we pick up the rehabilitation therapy, which we use called modified fashion. At least 2 hours, we feel it's relatively easy to implement. It has been tried to show this is just nearly effective as a traditional format of CIMT, which is 6 hours. And then we really want to, and then we really added the, transcranial direct current stimulation. So we have 3 groups. One is sham, which only gave you 30 seconds of the stimulation, just give you perception to the scalp, so the patient doesn't really tell. And the other group is a low dose, and at a 2 milliamp, which has been tested before. And this is the first time we test the high dose. So I hypothesize to see if there's overall effect among the 3 groups. And then we actually have called a go and a no go, and then really take a combination of the efficacy, safety all together to see if we can find a winning dose and then advance to the phase 3 kind of confirmatory study. And maybe Gottfried, you can talk about a little more detailed design, how we do the 10-session assessment.
Sure. So I think one additional point to what Wayne has already said is that we carefully looked at baseline to make sure that we are not in the spontaneous recovery phase of each one of the stroke patients. So one of the requirements was that we needed to have a stable baseline, which was determined by measuring an impairment score, the Fugel-Meyer scale, 2 times prior to baseline. There had to be a difference, or the only acceptable difference was either 2 points or less. So we were able to exclude patients that would show much more of a difference and potentially were still in the spontaneous recovery session. And then the actual intervention was 10 sessions, which was done over 14 days. And then on day 15, after randomization, after start of the therapy, was our first outcome assessment, which was also our primary outcome assessment. And then we also looked at the stability of this effect over time after an additional 30 days or an additional 90 days.
I see. One other question. So these were all stroke survivors. Were they within a certain range in terms of when they had their index stroke? And then number two, was there a certain kind of motor deficit?
Yeah.
So we use patients that were between 1 to 6 months after their stroke, and they were required to only have either a moderate or mild impairment, as was measured by the Fugl-Meyer impairment scale, which is a scale that goes from 0 to 66, 66 being basically not having any impairment. We accepted a cutoff of 54 or lower, so that we would have an additional 12 points to potentially gain, and hardly any or no of our patients actually really sort of like achieved ceiling effects in this outcome.
I want to add one point. Since we all use the CIMT as the rehab therapy, so we actually also require all those patients have a very residual distal hand movement. So just kind of, that's a population already determined by the XI trial back 15 years ago. Really think this is a group patient more like to benefit CIMT. So we added this and to ensure this is the population we want to focus.
So 5 years later, lots of patients, probably lots of gray hair, COVID in between. What did you find?
Well, you're absolutely correct. Both Gottfried and we look ourselves today. Yeah, we all both got a gray hair. And it's not easy to conduct a multi-center clinical trial during COVID. We tried it very hard, but it still have a little bit delay. But if we really look at the projection, the stroke net also have to be paused for enrollment for a couple months. And the intervention we propose actually is close contact. So even the 3 months later, the stroke net actually resumed and try enrollment. But because there's a specific institution policy regarding the close contact, it took us almost 7-8 months actually to resume activity. But overall, we did it pretty good, and then we, initially we hoped to finish the trial in 5 years, but in the end we finished in 6 years, 1 year delay, and so we did okay, yeah.
So the main findings were, or our main outcome measure was to look at change on day 15, and that change was calculated between our second qualifying baseline as well as the day 15 evaluation. We did not find an overall statistically significant difference between the three groups. And again, the three groups were: one group received sham simulation plus modified constraint-induced therapy, the other group 2 milliampere, and the third group 4 milliampere, each one of them paired with constraint-induced movement therapy.
And we also find that, and the intervention is safe, it's tolerable, it's also feasible. We really only have 3 patients actually loss of follow-up before the day 15, even during the COVID. We have trouble to sign up patient, but once they sign up and they really like the intervention we propose, they stay through the trials. So that shows if we can implement in the trial setting, means probably we can implement in the clinical practice. The other thing is, Gottfried just said there's no separation, but actually improvement persistent at 30 days after intervention and 90 days and after intervention, but they didn't really separate at a statistically significant level.
I see. And so why do you think the results were neutral? What would you speculate or hypothesize might explain why the results were neutral?
I'll start with this, and Gottfried can add a few more points. We've been really put a lot of thoughts how to look at this. And based on what we know, I think probably one thing is when we back 2018 for the study, we jumped from 2 milliamp to 4 milliamp. The whole field was very concerned, thinking maybe safety issue, but turned out there's no safety issue. But in the last few years, there are emerging signs showing with improvements with electrodes, we can actually deliver even high dose. Yeah, and it still is safe and tolerable. And they also found, and even with the 4 milliamp and the current inside the brain form called electric field strength, but this electric strength is still lower than the animal data, but the threshold that can reliable, influence in animal behavior. So we think probably the dose probably can go a little higher. I have you to,
Yeah,
I have
sure.
other comments.
So one of the effects of the pad size can be seen on Wayne's head. So that's a head that is about 5 × 7 centimeters, and through an insert in this pad, we're delivering the current. So even if you deliver 4 milliampere through this pad, there is something that we can measure, which is current density or total combined charge. Considering the pad size, it's still a relatively lower number. So you can imagine that what we call current density would actually go up significantly. For example, if we use a pad size that would be half of that, more centered, for example, over the motor hand region, that could give us easily, even if one would stay with 4 milliampere or move it higher to what current machines seem to allow us to 4.5 or 5 milliampere, we would get a significantly higher current density. At the time when we designed this trial, we basically chose this large pad size for two reasons. One was there was a lot of functional imaging studies done that told us where in the motor system would we see some changes when people recover. So we wanted to make sure that we cover all of these proposed hotspots that may actually show some functional changes. But we also wanted to make sure that we cover not just the motor region, but potentially sensory and premotor regions too, with a larger pad size. And we also wanted to consider safety, because we didn't want really to have any risk to cause skin burns or anything like this.
So this is a great thing about research. While the results are neutral, new questions arise. And so as you think about a future trial, clearly a higher dose is a consideration. Clearly a smaller pad size is a consideration. Are there other things? For instance, would you change the patient population in any way? Would you make patients more severe? Would you make them more acute, less acute? Would you change the patient? Or would it be the same type of patient and it will just be higher dose, smaller pad size? Any other considerations?
We select the right patient because remember, actually, the things we expect to see is a control group. Actually, is that going to actually improve in what we want to see? It's just the magnitude, the improvement seen in the TDCS group just didn't reach the statistical significance. Other things I would like to do is, this is the first trial on the stroke net, and we actually spent the first year really to standardize the site, to standardize outcome measurements, to have a standardized imaging protocol, TDCS protocol, CIMT protocol. Despite all this, and then add COVID, we see really a lot of side variation. And during my presentation, I point out, we have 15 sites, but only 129 patients. So the enrollment, ratio is only 2.3 patients per month. You saw this is really bad, but we're actually doing better than the other stroke recovery study, but we need to go faster. And and some of the sites also have to be withdrawn during COVID. So I think we need to invest more efforts on it, on the infrastructure, so we can try a little bit faster.
So I just want to thank Dr. Feng and Dr. Schlaug for this terrific contribution and work. Look forward to seeing the actual paper and reading it. I understand it's out in Lancet Neurology, so please look out for that. I also wish you the best in TRANSPORT2 and look forward to the findings for that particular trial. Thank you all for listening and watching. Hope you enjoy the rest of ISC 2025. Thank you.
Thanks, Dr.
Thank you.
Bruce Ovbiagele for the opportunity.
Thank you.